Okay, so I think we'll get started. There's probably more people that will be signing in as we go along, but we do have a fair amount of material to get through. This is the final webinar of 2021, and I usually do a year-end review of some of the interesting research published in peer-reviewed journals. So not necessarily the standard things that we usually talk about, which is, muscles and joints and that kind of thing. These are some really fascinating topics, and it speaks to where photobiomodulation therapy is going and perhaps how it can be used in the near future. So our guest speaker today, along with myself, will be talking about some of this research. And it's most interesting. So hopefully you get a chance to watch it entirely. If not, these webinars are recorded and that you should receive a link to watch it again, usually within a week or so of the original broadcast date. So I'm going to just mention a couple things here. Of course, 2021 was a tough year and continues to be a tough year because of the pandemic. And we saw a little dip in the amount of research published. When I searched PubMed for photobiomodulation, or PBMT, of course, that's the research term or the MESH term, which is a medical science library terminology, or low-level laser light therapy, which is the acronym used a lot still, but it's more of an older term. And when you do that, plug it into PubMed. I just searched on PubMed. It pulled up around 550 peer-reviewed research papers. The previous year was a little bit higher than that. And of course, the dip was because of COVID. So what I'd like to do now is ask Dr. Randy Santiago, who is our Director of Clinical Research, to turn on his, there you go, his webcam. And I'm going to ask him to share his presentation. If you have questions for Dr. Santiago, then just type them away in the Q&A box as he lectures, and he'll address those as we go along. So I'll ask Randy to share his screen now.
Oh, there you go.
Yep, and just go to full screen and we're good to go.
Oh. Start first with the first page. I just wanted to say good day, folks. This is my first time joining David here, so I request that you be nice to me. Just to put things in perspective, David is still the Director of Research. I'm the Director for Clinical Research. And the reason why we have that is because Meditech has gone to a different phase this past year. We are now actively pursuing a lot of clinical trials, or several clinical trials. 2 of them are already being conducted, and we're pursuing some more, hopefully by next year. And hopefully by 2022, 2023, we can also add to the amount of research publications out there that David could look for in PubMed. Just to introduce myself, I'm an ophthalmologist by training. I started working with Dr. Khan around 4 or 5 years ago. And I came back earlier this year after that change in the directions that Meditech is pursuing. I'd like to discuss the neuro stuff. I call it the neuro stuff because a lot of you are interested in neurological material, which photobiomodulation can be applied for. And I chose these research subjects based on the interest that I see a lot of people are asking me about with regards to email, as well as to help you, guide you when you come across certain studies, to guide you on how to review these studies. Let me start first with this study exploring the use of intracranial and extracranial or remote photobiomodulation devices in Parkinson's disease, a comparison of direct and indirect systemic stimulations. The authors who made this study have made a big change in the way I view photobiomodulation, especially for neurological purposes. You see a lot of people use intracranial devices for photobiomodulation using just LED. And these guys sort of opened my eyes towards what exactly are we doing. This is just a short description of Parkinson's disease, which I'm sure a lot of you are aware of. The current mechanism of action being explained for Parkinson's disease is the death of dopaminergic neurons. gliosis or scarring, vascular dysfunction and blood-brain barrier breakdown, and abnormal circuitry. And as you may all know, there isn't any cure yet for Parkinson's, but there are available treatments right now, including dopamine replacement therapy and deep brain stimulation. Applying photobiomodulation therapy causes, as we all know, cytochrome C oxidase stimulation or increased ATP synthesis. There's less mitochondrial membrane water viscosity, also leading to increased ATP synthesis, vasodilation due to nitric oxide release, and the release of reactive oxygen species, which I will discuss a bit later on the other studies, because the definition of reactive oxygen species seems to have some controversy with a lot of folks. So with regards to direct treatment, in vitro, in test tubes, they've demonstrated that photobiomodulation therapy causes reduced cell death, increased ATP, and decreased oxidative stress in cell culture neurons exposed to Parkinsonian toxins. In vivo, in animal studies, transcranial application in MPTP-treated mice and transgenic mice, photobiomodulation protected many dopaminergic neurons from toxic insults and subsequent degeneration. Take note that when we say transcranial in animal studies, that means it's actually exposing actual brain tissue. They don't put the photobiomodulation devices on intact skull, but they remove the skull and expose brain tissue to photobiomodulation therapy. There's also an intracranial application.
Randy, that might be a little bit challenging in humans, right?
Exactly, which is what we'll discuss a bit later. In primates, they used fiber optic implants, intracranial application. And photobiomodulation treated MPTP monkeys had a greater number of surviving dopaminergic neurons in the substantia nigra, a reduction in scarring or gliosis, and influenced the expression of glial-derived neurotrophic factors in the striatum of MPTP-treated monkeys. There's also an enhanced blood-brain barrier integrity and reduced cerebrovascular leakage, leading to improved locomotion. And these are the terms that I've come to sort of accept and apply in our treatment here in the clinic, the term remote photobiomodulation. I haven't seen a lot of people use this term except in Australia, and I'd like to introduce you to this term because it makes a lot of sense in the way we treat neurological conditions. It's indirect systemic stimulation, and they consider extracranial treatments using LED devices as just remote, not direct treatment. With laser probes, only 1 to 3% of light energy actually penetrates the skin and skull, with less than 1% of that light penetrating 12 millimeters of brain tissue. Photobiomodulation, though, has indirect systemic protective effects that can be harnessed to eliminate practical barriers to implementation. In an MPTP-treated mouse model, irradiating the dorsum of the animals with 670 nanometers following MPTP injection, while simultaneously shielding the head with aluminum foil, yielded substantial neuroprotection. MPTP-treated mice with photobiomodulation of the body had more dopaminergic neurons than sham-treated MPTP mice. This points towards the fact that we've never treated the head, exactly just the body, and yet we've managed to gain some benefits. Some potential mediators that have been proposed include stem cells, particularly mesenchymal stem cells, immune cells, cytokines and chemokines, mitokines, and the microbiome. It is possible that the absorption of light by the skull, and superficial layers of the brain triggers mechanisms that confer protection to remote, non-irradiated deeper regions of the brain. Currently, this is what we do for brain treatments. We usually have a helmet that you put on the cranium, applying LED lights. Would that be enough to directly affect brain tissue? With the concept of remote photobiomodulation, it doesn't, and we're actually treating mostly superficial structures and indirectly affecting brain tissue. Overall effect on people with Parkinson's disease using transcranial devices, there are motor improvements we're seeing, particularly with tremor, gait, fine finger control, writing, and facial animation. And there are improvements in sleep quality, energy levels, rekindling of interest in previously neglected devices, cognitive function, increased social engagement and self-confidence, as well as improvement in olfaction, anxiety, and depression. Do take note that these are not cures. And we do have a lot of patients that we treat with Parkinson's disease here in the clinic that have demonstrated these improvements, but they don't cure Parkinson's. At most, we probably delay symptomatology, but I think that delay is important. If you can get more life satisfaction, that would be a big improvement in their lives. Photobiomodulation applied to cells in culture, which relies solely on direct stimulation, has been shown to be neuroprotective, indicating that indirect stimulation is not essential for neuroprotection. On the other hand, photobiomodulation applied remotely to a distant body part, like in this case, the dorsum of the animal, or in our case, treating the cervical spine, relying solely on indirect systemic stimulation offers neuroprotection also, indicating that direct stimulation is not fundamental to the process. And that sort of changed my current mind ideas on treating cranial processes. Actually, in the 2 clinical trials that we're pursuing, we're not applying cranial treatment anymore. We're just applying cervical spine treatments. The next study is photobiomodulation for the aging brain. Aging is a condition, a multifactorial biological process characterized by a decline in neurophysiological functions. Both David and I are currently suffering from. Mechanisms of action of PBM on the brain.
What was that?
Yeah. No, I said we're getting more wiser. So mechanisms of action of PBM on the brain. First is the capacity of cells to absorb photons of red to near infrared light from 620 to 110 nanometers by wavelength by mitochondrial photoacceptors, specifically the cytochrome C oxidase. The CCO molecule has a heme, A and A3, and copper, CUA and CUB centers, with red and infrared spectral absorption peaks. PBM used with longer infrared wavelengths that is different from or more longer than the current accepted infrared peak of 825 to 840 nanometers, such as 164 nanometers, 168 and 172 nanometers, are also able to promote beneficial effects on the brain. The current explanation for this so far seems to be more its effect on water. They're claiming that photobiomodulation decreases the viscosity of intermitochondrial water, releasing to more ATP production. Transcranial 1064 nanometer photon absorption causes photooxidation of brain CCO in vivo and triggers a hemodynamic response, resulting in greater brain oxygenation in both young and older people. That is not due to thermal effects. There's an increase in oxygen consumption and ATP production, and promote nitric oxide release and increase in mitochondrial membrane potential. There's a brief, I highlighted the word brief, increase in reactive oxygen species, because reactive oxygen species are actually signaling molecules that tell the nucleus of a cell to promote several brain development factors. So the brief increase is not a problem, but I'll discuss that in a prospective study later regarding reactive oxygen species and whether this should be harmful or not. There's a release of nitric oxide, which stimulates vasodilation and blood flow that promotes ATP production. On animal studies, they showed that photomodulation causes D-galactose-induced aging mice to exhibit an increase in CCO activity. 670 nanometers wavelength laser and 4 joules per square centimeter fluence decreased the marked intensity of oxidative stress markers in the neocortex of transgenic mouse models. And there's an attenuation of the oxidative damage in neurons caused by amyloid toxicity in animals. In human studies, since we can't do direct studies of brain cells in humans, there's an increase in systolic and diastolic velocity of the left middle cerebral artery and the basilar artery after 8 laser sessions using 627 nanometers, 70 milliwatts per square centimeters irradiance, and 10 joules per square centimeters fluence for 4 weeks in healthy elderly women. The prefrontal cortex PBM using laser, and I highlighted laser because so far laser seems to be the only modality that's been proven to actually reach brain tissue directly. And with laser at 1064 nanometers, 250 milliwatts per square centimeters, irradiance at 60 joules per square centimeters fluence, was able to increase the resting state EEG alpha, beta, and gamma power, and more efficient prefrontal bold fMRI response, facilitating cognitive processing in the elderly. PBM of the human prefrontal cortex in older adults with 1064 nanometer wavelength laser led to significant PBM-induced increase in oxidized CCO during laser stimulation, again, laser, followed by significant post-stimulation increase in oxygenated hemoglobin and a decrease in deoxygenated hemoglobin using spectroscopy. And there's an interesting study at the end, my last presentation, that you could probably apply this to. For inflammation, PBM is able to reduce the exacerbated inflammatory response to amyloid neurotoxicity in animals. And PBM with red laser for 8 months in mice aged 5 months, mice live probably a year, led to a decreased number of astrocytes and microglia in the striatum. Effect on apoptosis or cell death. The 2 genes that are responsible for directing your cells to die, BCL-2 and BAX. If there's an increase in their ratio from BAX to BCL2, there is increased cell death. And photobiomodulation with red or near-infrared laser was able to regulate the BAX BCL2 ratio and reduce an apoptotic protein in the brain of D-galactose-induced aging mice. A 5-day protocol of PBM with near-infrared laser at 808 nanometers restored the BAX BCL hippocampal ratio in animals with amyloid neurotoxicity. PBM can promote synaptogenesis and increasing axonal transport. PBM increases brain-derived neurotrophic factor, which is different from glial-derived neurotrophic factor expression. That neurotrophin stimulates synaptogenesis, in turn altering cortical and hippocampal dendritic morphology. To put things in perspective, reactive oxygen species are the ones that are usually responsible for directing the nucleus of your cells to produce brain-derived neurotrophic factors. PBM is able to restore axonal transport caused by impaired mitochondrial function. Light penetration in the brain. The best penetration results were found using a wavelength of 808 nanometers, reaching a depth of 2.52 millimeters in brain tissue. And these are lasers. The best combination was using the transpenoidal approach with the same wavelengths. A combination of 3 representative PBM wavelengths, 660, 810, and 1064 nanometers, using Monte Carlo simulations for photon delivery to the human head, demonstrated that 1064 nanometers is the optimal wavelength due to its reduced light scattering. But these are Monte Carlo simulations, which is a computer program. The thing that Monte Carlo simulations don't take into account is blood flow and other physiological mechanisms that go on in living tissue. So even though with this simulation, 1064 is the ideal wavelength that they're mentioning, there's always a trade-off, as they say, to achieve optimal PBM of human brain tissue between absorption of light by CCO, which is best between 660 and 808 nanometers, and the depth of light penetration. And then there's the biphasic dose response effects of PBM. Cortical cells irradiated in vitro with near-infrared laser with 810 nanometers using fluences of 0.03, 0.3, 3, 10, and 30 joules per square centimeter showed that the peak efficiency for increasing ATP and mitochondrial membrane potential was attained with a fluence of 3 joules per square centimeter. That doesn't mean that you should use 3 joules for your treatment of patients. Take note that these are in vitro. These are cells in culture, without the skull, without the skin. In reality, in practice, most likely we need higher fluences in treating brain tissue. Most studies show 10 or more fluences for neurological treatments. The beneficial cognitive effects of PBM on the aging brain include in older adults with subjective memory complaints subjected to, again, laser PBM once a week for 5 weeks, noted an improvement in cognitive function, in psychomotor vigilance tasks, in tests of sustained attention, and the delayed match to sample task, and tests of visual working memory. PBM in elderly people diagnosed with dementia led to an improvement in executive function and a significant improvement in sleep and mood. The next study is another review study, the current application and future directions of photobiomodulation in central nervous system diseases. For stroke, in animal studies, PBM improved behavioral performance and had long-term benefits in rabbit embolic stroke models. Pulsed wave showed better results compared to a continuous wave, and PBM significantly increases mouse neural progenitor cell proliferation and promoted the proliferation and differentiation of neural progenitor cells in the peri-infarct zone, and the switch from an N1 microbial phenotype to an anti-inflammatory M2 phenotype. In human studies, I don't know if you guys have heard of the neurotherapy effectiveness and safety trials. They mentioned the 3 NEST studies, NEST 1, 2, and 3, which corresponds to phase 1, phase 2, and phase 3 studies. With NEST 1, which is a test of efficacy, dosage, and safety, more patients in this test group, 70%, had favorable outcomes than controls, as assessed by the National Institute of Health Stroke Scales and Modified Rankin Scales. When they went to NEST 2, which is the same studies except that they recruit more patients, in this case 660 patients, the group given transcranial laser therapy showed slightly but not significantly better outcomes than the control groups. It did prove that the treatment itself was safe, so they decided after NEST 2, even though there wasn't any significantly better outcome, let's continue to NEST 3, which is pre-marketing, which unfortunately was prematurely terminated for futility because there was an expected lack of statistical significance. What does this mean? Does this mean that photobiomodulation is not really an effective treatment for stroke? Not if you take into consideration the next 2 statements, that there's an accelerated recovery in motor functions observed in a study of 15 patients with post-stroke spasticity, and it was effective in ameliorating post-stroke shoulder pain in some patients. Dr. Michael Hamblin said that we shouldn't take the NEST 3 outcome of premature termination too seriously because, one, there were some issues with the NEST studies. One, they applied photobiomodulation therapy in patients recruited from the emergency room. So patients with acute strokes coming to the emergency room were not treated for other treatments for stroke, but were given photobiomodulation therapy. So in clinical practice, a lot of us don't treat these types of patients. We don't go to the emergency room and apply light immediately to stroke patients. We usually get them after they've been treated in the emergency room, and our aim is to improve function after the stroke itself. So my intake on this is in future studies, we should probably focus not on acute strokes, but on patients who go to rehab centers aiming to regain more function. And maybe we will have a better outcome. For traumatic brain injuries in animal studies, they've noticed a substantial improvement in better outcome with pulsed laser mode at 100 Hertz. Take note that they used 100 Hertz in mice. However, recent studies and current studies these days show that the lower pulse frequencies were more effective. In this case, they mentioned 10 Hertz was more effective than 100 Hertz and continuous wave with a wavelength of 810 nanometers. Photobiomodulation affected local and systemic immune functions following cryogenic brain injury by modulating tumor necrosis factor alpha, interleukin-1 beta, and interleukin-6. These are all inflammatory modulators. They also show that PBM prevented neuronal death and severe astrogliosis, thereby promoting wound healing. Mice in the treatment group had smaller lesion sizes at 28 days and fewer degenerating neurons, suggesting that PBM therapy may encourage neurogenesis. In human studies, they noted an improvement in learning ability, which was positively correlated with treatment duration. And in clinical symptoms, including depression, anxiety, headache, and insomnia, were reduced after laser therapy, which might be associated with increased regional cerebral blood flow. And these improvements we've all experienced in our clinic or observed in our clinic here in Etobicoke for a lot of our concussion patients. For Parkinson's disease, again, 810 nanometer laser therapy had more immediate therapeutic effect than 670 nanometers. And PBMT applied before, at the same time, and after injection of MPTP in mice produced similar outcomes in their Parkinson's disease model. In addition, exposure to 670 and 810 nanometer near infrared, either together or sequentially, produced better results than either alone, especially when they were applied together. Near infrared was shown to reduce amyloid beta plaques in the brains of transgenic Alzheimer's disease mouse models in a dose-dependent manner. There was a reduction in both neurofibrillary tangles and amyloid beta plaques in 2 different transgenic mouse models after near infrared treatment. And photobiomodulation improved spatial memory and behavioral performance. Near infrared also induces proliferation of CD11b positive monocytes, which are white blood cells which appear to remove plaques by phagocytosis. In human studies, they've noticed cognitive improvement and better emotional control after a 4-week treatment period in 5 patients. No side effects were observed. They've noticed increased cerebral perfusion in 8 participants diagnosed with dementia after 12 weeks of photobiomodulation therapy. However, in another study and another controlled trial with only 11 participants, there were no significant difference found between PBM group and controls. This is probably because of the small sample size. For major depressive disorders, in animal studies, low-level laser therapy with just 10 hertz pulse wave, 810 nanometers, significantly decreased immobility time in the chronic mild stress model of depression compared with citalopram, or an antidepressant. However, no significant reduction in anxiety-like behavior was detected in the elevated plus maze test. There was an antidepressant-like effect of PBM observed in the model of reserpine-induced depression. Near-infrared treated groups showed better outcomes in behavioral despair tests and found that this improvement was associated with the modulation of neurotransmitter levels and improved mitochondrial function in the prefrontal cortex. And PBM has been shown to reduce oxidative stress and superoxide anion levels, which is a reactive oxygen species. Studies in a randomized double-blind controlled study with 30 patients with depression, a significant difference was observed in Beck depression inventory scores between the laser therapy and control groups. High-powered near-infrared provides persistent and better results compared with low-power near-infrared, and laser therapy combined with attention bias modification can enhance cognitive improvement. They've also described other applications for PBM, including the amelioration of symptoms in a mouse model of multiple sclerosis, an improvement in autism spectrum disorder in children and adolescents of 5 to 17 years of age after PBM treatment, and it can prevent ischemic injury to neurons after global cerebral ischemia caused by cardiac arrest and neonatal hypoxic ischemic encephalopathy, or basically a stroke in newborns. The next study is a photobiomodulation for Alzheimer's disease, has the light dawn, and this is authored by Dr. Michael Hamblin, which is probably the pope of photobiomodulation surgery these days. Quick definition of Alzheimer's disease: it's the most common type of dementia, followed by vascular dementia and Lewy body dementia. 70% of the risk is probably genetic. However, there are other risk factors that can be involved, including depression and hypertension. Alzheimer's disease is characterized by diffuse atrophy of the entire brain, especially the cortex, accompanied by extracellular beta amyloid plaques and intraneuronal neurofibrillary tangles are composed of hyperphosphorylated tau protein, which is the diagnostic modality of definition for Alzheimer's disease. Several points to ponder. One is the failure of several drug trials that have targeted the amyloid peptides and amyloid plaques that has led to the concept that the amyloid plaques may be markers rather than causes of brain deterioration. If you recall, there was a controversy regarding the FDA approval of a certain drug for Alzheimer's. This drug actually targets amyloid plaques. And there were a lot of doctors who say that it doesn't really work, so why was it approved? For tau proteins, which is a microtubule-associated protein, current treatments are now focused on these. And these they so far have proven that these seem to be to partially cause some of the brain deterioration secondary to Alzheimer's disease. Other hallmarks are neuroinflammation and reactive gliosis or scarring. Accumulating evidence suggests that the microglia with the M1 phenotype are important players in Alzheimer's disease. Not only do the M1 microglia pump out pro-inflammatory cytokines, but these cells downregulate their phagocytic functionality and therefore fail to clear the amyloid plaques. Any therapy, and that includes photobiomodulation therapy, that can switch the microglial phenotype from M1 to M2 may be helpful for Alzheimer's disease. And I've mentioned that earlier in a mouse study that showed that PBM can switch M1 to M2. Vascular dysfunction is often described as causing vascular dementia, but there is increasing evidence that it plays a role in Alzheimer's disease as well. These microhemorrhages have been correlated with plaque formation and could act as triggers to activate the innate immune system. They could also be indicative of sites of breakdown of the blood-brain barrier, which is considered one of the early markers of cognitive dysfunction. And finally, there's oxidative stress. However, although a diet high in antioxidants offers some protection, supplementation with antioxidants has largely failed to show any benefits. Reductions in mitochondrial activity and glucose metabolism are seen in Alzheimer's disease. And then there's the effect of gut microbiome. There are a lot of neurologists and scientists these days that are taking the concept of the gut-brain axis more seriously. Actually, in the University of Toronto, the neurology department is now investigating whether gut microbiome can actually influence brain function. There's a question there. Are there any future plans to study PTSD and laser? Yes, actually, I'm going to discuss type of PTSD later. Also, did you say that you started to focus on the cerebral spine versus putting the laser on the scalp directly? Not the cerebral spine, the cervical spine. Yes, we are starting to focus on doing that rather than putting on the scalp. Any work with ADHD or dyslexia? Good question there. We've tried previously applying PBMT on kids with ADHD. And the most that I can mention is they yawn after the treatment and they become a bit relaxed. Of course, the only way to notice, to see this is if we follow those kids so long as they grow up, if they become a bit more focused. But with that current treatment, those kids, I think we've done it on 2 kids, did seem relaxed after treatment. Are there any studies or even a hint of insight on laser's effect on activating the vagal nerve? Good question. One of the reasons why I focus on the cerebral spine, the cervical spine, is to focus on the vagal nerve. So we're hoping that that would shed some light on the effect of the vagal nerve on a lot of functions. Of course, we can't do an actual dissection to see if it does. But if it improves on a lot of the autonomic nervous system functions, which is what the vagal nerve does, then maybe it can prove that photobiomodulation on the cervical spine can affect that nerve. Any work? Oh, there's a lot of questions here. Any work or studies with epilepsy patients? We've had one patient that we've treated who has a severe form of epilepsy, uncontrolled. I can't say that the treatment itself helped out. We were trying to combine the pulsations at the time she was having a seizure attack while in the clinic, and it seemed to calm the seizure down. This is not a study, this is just a clinical case report, and I can't confirm whether that actually helped out with the seizure. I've lost track with that patient after I left Meditech 2 years ago, so I don't know if they're still using the device. Vagal nerve and cervical specifics in treatment. How are outcomes measured? Maybe I'll mention a quick introduction to our studies that we're trying to conduct later regarding that. Any work or studies with MECFS or long COVID? That's another interesting question. I made a study protocol on long COVID because long COVID these days are considered similar, the symptoms are similar to chronic fatigue syndrome, fibromyalgia, and is considered a post-viral syndrome. I made the protocol, I submitted it to a group. They're still reviewing it. I don't know what will happen to it if ever we're going to pursue it, because even long COVID itself, the definition of long COVID, not everyone accepts it yet. Are you studying specific protocols to stimulate vagal nerve to treat anxiety? Not yet. That may be something we'll address in the future. Okay, so let's continue with some of these studies. In Alzheimer's disease, animal studies, 810 nanometer lasers to the heads of amyloid beta protein precursor transgenic mice significantly reduced these plaques in a dose-dependent manner, leading to a reduction in amyloid load, soluble amyloid beta proteins, and brain inflammatory markers. However, as I've mentioned earlier, there are some folks who are thinking that amyloid beta plaques are not the actual causes of Alzheimer's, that they're actually just markers. So whether this is true, we don't know yet. They've treated transgenic Alzheimer's disease mice, and it showed improved cognitive performance as measured by the object recognition test and the fear conditioning test after PBMT 6 times at 10 days of intervals for 2 months, starting at the age of 4 months. Immunohistochemical analysis of brain slices showed that PBM-treated mice had a 68% reduction in amyloid plaque burden. And again, as I mentioned earlier, there are some groups that are thinking that amyloid is probably not the cause of the symptoms of Alzheimer's disease, but it's just a brain marker. An 810 nanometer laser was connected to a fiber optic cable and used in contact with the tibia. Now take note, this is not the skull, this is the tibia. This is a big bone in the leg after making a small incision in the skin to deliver 1 joule per square centimeter. I think the point of this is what I mentioned earlier regarding remote photobiomodulation, which was actually observed at the dawn of photobiomodulation itself by Dr. Mester, that treating one limb could have an effect on the other limb. And I know in Australia, where the concept of remote photobiomodulation, it seems to be well accepted now. I know an anesthesiologist who's treating chronic regional pain syndrome in one arm by treating the non-affected arm, because treating the affected arm seems to increase pain, since these are neuropathic pain. This is a form of neuropathic pain, and it seems to work. One more question. Will you cover research on microbiome? Not today, maybe on subsequent webinars. I'll do some research on using the PBMT for the microbiome.
Sorry, if I can just comment. Our last advanced training, Dr. Ben Ewan did talk a fair amount about treating the gut biome in clinical practice. So if you're interested in that, you can go to our website and look up the last training. It was actually on cosmetic conditions, but he talked about the link between the gut biome and skin. in particular, but he does generally talk about the gut biome. Has a long lecture on that if you are interested.
With direct injection of different types of amyloid beta peptides into the hippocampus in rat models, 808 nanometer light delivered to the head for 2 minutes per day for 5 days ameliorated the neurodegeneration of the hippocampus and improved long-term spatial and recognition of memory. 627 nanometer laser for 100 seconds at 7 joules per square centimeters for 21 days significantly reduced the amyloid beta plaques and improved spatial memory and behavioral and motor skills in treated animals on day 21. 850 nanometer laser and LED and 625 nanometer LED, all pulsed at 10 hertz and surrounded with a ring-shaped magnet, creating a 200 MT static magnetic field delivered 8.4 joules per square centimeters over 10 minutes, was applied once a day for 7 days on top of the head or the center of the abdomen, or both. Again, abdomen, not directly on the head. Protection from neurotoxicity was seen whether the PBM was applied to the head and the abdomen together, but not to either alone. This actually points toward what David was mentioning regarding the gut microbiome. Mice showed improved memory, while amyloid beta plaques, tau proteins, and oxidative stress, apoptosis, and neuroinflammation were all reduced. Question, are the cervical spine treatments done on neck shaved to remove hair? To be honest with you, one of the things they're concerned about with regards to treating neurological conditions is hair significantly absorbs a lot of those light wavelengths. So I would presume if there is less hair, it would be more effective. We don't shave hair here, of course, especially for treating women. If you have long hair, we just ask them to lift them up so that we can have access to the cervical spine. Are there any concussion protocols for use with laser that have been released yet? If you're talking about our protocols, I have one that we're submitting to a journal. It hasn't been published yet. I don't know if you can access it. There was a pre-publication release that they did using impact or a neurocognitive assessment test to show improvement in cognition pre and post laser therapy. For those that have a P120 or P180 home unit, could this be used on the cervical spine for prevention, treatment of early cognitive decline, weekly or bi-weekly? Yes, you may use that for the cervical spine. My only concern with regards to the personal units is, of course, you cannot tailor your treatment specifically for each patient. So it might be worth it if you know what the protocols are, what the dosages are, to use certain dosages that are not prescribed for, say, the cervical spine, say, for instance, for the face or for the ankle, and use those protocols for your treatments. In human studies, 5 patients died.
Sorry, I don't mean to interrupt, Randy. I'm just going to say maybe we'll hold off on any questions right now to let you get through your material, because apparently I'm supposed to talk as well too at some point.
Sorry. Okay, so let's finish these guys first and then let's discuss later. For human studies, 5 patients diagnosed with mild to moderately severe dementia using combined transcranial plus intranasal PBM to treat the nodes of the default node network. Showed that there was sleep improvement at 12 weeks, cognitive improvement, fewer angry outbursts, less anxiety and wandering. There were no negative side effects. Precipitous declines were observed during the 4-week follow-up, no treatment period. 8 patients, 4 TPBM and 4 usual care patients diagnosed with dementia were treated at home. 3 times per week, the participants were assessed with the Alzheimer's Disease Assessment Scale Cognitive Subscale, or the ADAS-COG, and the neuropsychiatric inventory at baseline and 6 and 12 weeks. And with arterial spin labeled perfusion, magnetic resonance imaging, and resting state functional MRI at baseline and 12 weeks. After 12 weeks, there were improvements in ADAS-COG and NPI, increased cerebral perfusion as evidenced by magnetic resonance imaging, and increased connectivity between the posterior cingulate cortex and lateral parietal nodes within the default mode network in the TBM group. A small pilot double-blind placebo-controlled trial in subjects diagnosed with dementia, 11 cases, to assess the effects of 28 cognitive 6-minute transcranial sessions of near infrared PBM using 1060, 1080 LEDs embedded in a helmet, showed improvement in executive function, clock drawing, immediate recall, practice memory, visual attention, and tasks switching, as well as a trend for improved EEG amplitude and connectivity measures. A patient received twice daily PBM therapy at home using 3 different wearable LED devices. This is actually an interesting study. I'll discuss in my next presentation on studies, on prospective studies regarding this specific case. For the first week, a prototype transcranial LED light helmet and body pad were used containing a mixture of 635 nanometers and 810 nanometer LEDs. The body pad was placed on various areas in the lower back, and the helmet was worn while seated. After the first week of treatment, an intranasal LED device, 10 hertz, 810 nanometers, was initiated in the left nostril twice daily. All 3 devices were applied at the same time for 25 minutes. And the patient showed a significant improvement in the MoCA test score from 18 to 24. It's still below normal. 27 is normal. And in the working memory questionnaire score from 53 to 10. The olfactory dysfunction was reversed as measured by the Alberta smell test, and peanut butter odor was detected. Quality of life measures improved and caregiver stress was reduced. 48 patients received transcatheter intracerebral PBM with an intravascular fiber optic cable. Advanced to the distal sections of the anterior and middle cerebral arteries via the common femoral artery, delivering 632 nanometers of light. And PBM-treated patients showed improvement in cerebral microcirculation, reduction of dementia, and restoration of cognitive functions. The control group did not show any significant changes. So for parameters, Dr. Hamblin set out the following questions, I guess for all of us to ponder. Is dosage of 10 to 60 joules per square centimeters enough, which is better, 10 or 60? I leave that up to you guys. I usually don't go as high as 60 joules per square centimeters for brain treatment. I would stick to around 10. That's the fluence that I'm comfortable with, I guess. Pulsing at 10 hertz to stimulate alpha rhythms or 40 hertz to stimulate gamma rhythms. There was one person who asked me before regarding this, why does the Vialite device use 10 hertz instead of what we usually use, which is around 50 to 100 hertz? And they're trying to simulate EEG waveforms, 10 hertz being the alpha wave, and 40 hertz being the gamma wave, and in between that 10 to 40 is the beta wave. But so far they've noticed that pulsing at low levels, at low hertz or frequencies, is better than pulsing at higher frequencies like 100. So regardless of whether we start at 10 and go up to 40, I think it's fine. They seem to provide some form of benefit as opposed to pulsations at higher than 100 hertz per second. Intranasal light delivery, that's a very good question. The only device that I know that uses intranasal light delivery uses LED lights. The concept of intranasal light delivery is that you could reach the sphenoidal bone better, which is the thinnest bone in the cranium, and thus reach the brain. I tend to believe that intranasal light delivery actually eliminates the blood vessels in your nose more. There's a rich amount of blood vessels inside your nose, and people could actually die if you get hit in the nose and a large amount of blood is lost. So I tend to believe that that's actually more because of light delivery towards the blood vessels in the nose than it actually reaching brain tissue. Intravascular approach, that would be a good option if it's currently available, but it's a very invasive approach. So I don't know if a lot of people who do the intravascular approach. Applying PBM to stimulate autologous stem cells in the bone marrow of the tibia. This is remote photobiomodulation. I think it's a good idea. Again, it's a bit too invasive for me, but maybe there are some people who are pursuing these studies. And treatment combined with coenzyme Q10. Our medical director, Dr. Zidney, always prescribes coenzyme Q10 for a lot of patients with brain issues, primarily because coenzyme Q10 is used, it's a cofactor in the production of ATP in your cytochrome C oxidase. I guess dietarily you need it. I don't know if it exactly has an effect on improving outcomes. So now we go to 3 prospective studies, and I'd like to discuss them with you because I found these 3 rather interesting. The first is transcranial photobiomodulation to improve cognition in Gulf War illness. So Gulf War illness is sort of like PTSD. It's composed of 1 or more chronic symptoms lasting more than 6 months from at least 2 of 3 symptom categories: musculoskeletal, muscle or joint pain or stiffness, mood or cognition, and fatigue. Neurotoxicant exposures are thought to be the main causes of symptoms associated with Gulf War illness, with direct damage to mitochondria. Immune dysfunction may also be a factor to consider. So for the methodology of the study, in the inclusion criteria, they must be a veteran employed in the 1990 to 91 Gulf War to the Kuwait theater, meets criteria for Gulf War illness, which is that you have to have the presence of 1 or more chronic symptoms lasting more than 6 months, musculoskeletal, mood, and fatigue. 38 to 65 years and physically able to travel. Score at least 2 standard deviations below the standardized norm on at least one of the following neuropsychological, screening tests, or 1 standard deviation below the standardized norm on at least 2 of them. And these neuropsychological screening tests are the trail making test A and B, controlled oral word association test, California verbal learning test 2, color word interference test, and the Stroop test. Complete the following screening questionnaires: the word reading subtest, test of memory malingering, short for McGill pain questionnaire, the visual analog scale for pain, and PTSD checklist for civilians. Exclusion criteria: less than 38, greater than 65. Presence of other neurodegenerative diseases such as ALS, Parkinson's disease, or dementia, presence of a life-threatening disease such as cancer, presence of severe mental disorders such as schizophrenia or bipolar, and current substance abuse or active treatment within the last 6 months. So I'm showing you this picture because I'd like you guys to decide on this picture. Methodology: this is a prospective randomized double-blinded interventional clinical trial. 63 eligible participants were recruited, only 48 completed the study. The LED intervention applied simultaneously included a helmet, LED lined helmet, LED cluster heads on the ear, and an intranasal LED applicator on both nostrils. And I don't know about you guys, I think this is overkill, but we'll see what happens with all these LED devices. There was no laser use, just LED. Blinding: the participant and the assistant administering the treatment wore goggles, the diode laser safety goggles, model 55 LS diode 55 Philips safety products. Blocking 600 to 900 nanometers wavelengths to block visual perception of 633 nanometers. Take note, these goggles are similar to the goggles that we use. You don't see red, but you can see light. So I don't know how blinded the participants and the assistants are. It seems there's an opaque layer here, so the participants couldn't see lights emanating from the helmet. But I don't know how much blinding that is. Even though you don't see red, if you can see a green light, then I think you can still know if you're being treated or not. The half-hour LED treatments, sham or real, were scheduled for twice a week with at least 48 hours between treatments for 7.5 weeks, or a total of 15 treatments. So here are the results. I'm not a statistician. That is my weakness. That's why I always have a statistician on hand. I do respond to images. And you can just tell from these images, real being the dark line and the dotted line being sham, that there might be some problems with regards to the starting phases. See here, the sham cases had less raw scores, and the real patients had more raw scores, so they had more to improve on. And you can see that there's substantial disconnect between the sham and the real patients. So is this statistically significant? We'll see. Here are the other tests done. And again, there's a substantial disconnect between the starting points within the real and the sham patients and in the end results. Same here. So in conclusion, the author said this study was underpowered with only 48 recruits, which for me is still a lot of recruits or a lot of subjects for pilot study. This is not a phase 1, phase 2, phase 3 study. This was just a pilot study with large heterogeneity at entry, which explains why these starting points are very far off, because these are very heterogeneous populations, which likely contributed to significance or trend to significance for only two of all those questionnaires and tests that we did. Only 2 of them were statistically significant, and they used the term trend to significance, basically meaning if we allow this to continue a bit longer, maybe there might be some statistically significant outcome. But it showed that if it's only for 2 of these many questionnaires, I wouldn't consider that a very significant outcome. Gulf War illness veterans who exhibit cognitive impairments, particularly in the domains of executive function, working memory, sustained attention, or verbal memory, are likely good candidates for future PBM studies. I'm sure they could prove that it's safe, despite the fact that there are like 3 different devices all turned on at the same time. And they're all LEDs. There were no lasers involved. Controlled studies with newer transcranial LED home treatment devices are warranted. This is expected to increase enrollment. So overall, my view of this study, it didn't show good results. With LEDs, I feel like there's an overkill with regards to the amount of treatment used. And maybe applying it to the cranium is not the way to go, is the way I view this. Again, we are all free to our own opinions on these stuff, but that's how I view the study. The next interesting study is the effects of concomitant use of hydrogen water and photobiomodulation on Parkinson's disease, another pilot study. One Parkinson's disease pathogenesis mechanism is the excessive net production of reactive oxygen species and oxidative damage. Molecular hydrogen is found to be a potent and possibly therapeutic antioxidant in both in vitro and in vivo studies. H2 application could be easily achieved by drinking H2 dissolved water. The studies aim to test the safety and effectiveness of the combination of PBM and H2 water for non-invasively improving mitochondrial function and suppressing oxidative stress in PD. There are some studies in Japan on the use of hydrogen dissolved water for the treatment of Parkinson's disease. I personally don't know how much of the hydrogen gets absorbed once you swallow it and it gets absorbed in your bloodstream. How much of it eventually reaches the brain. And the concept of photobiomodulation actually encourages the very brief production of reactive oxygen species, because these would serve as neurotransmitters that encourage your nucleus to produce brain-derived neurotrophic factors. So I don't know if this study itself might decrease the production of all reactive oxygen species and therefore prevent the production of brain-derived neurotrophic factors. 17 participants received daily H2 water and PBM simultaneously for 2 weeks. The adverse events and the Unified Parkinson's Disease Rating Scale scores were recorded. Inclusion criteria included Parkinson's disease patients at stage 2 and stage 3, diagnosed by a board-certified neurologist, age between 30 and 80, generally healthy as indicated by recent physical examination, and if taking any psychotropic medications should be stable in the past 2 months. For photobiomodulation, they used an LED diode array similar to ours with near infrared at 940 plus or minus 10 nanometers wavelength and intensity of 6 milliwatts per square centimeters at 10% power. Placed on the posterior aspect of the neck or the cervical spine midline pointing to the midbrain, 5 days per week with no direct skin contact. H2 water, they used the Imitsu Platinum H2 water brand, which has 2.5 parts per million of dissolved hydrogen. Results, the overall Parkinson's disease severity, sum of UPDRS parts 1, 2, and 3 scores, significantly decreased after only 1 week of PBM plus hydrogen water. This improvement continued over the second week of therapy. And their conclusion was the present study demonstrated that the combination regimen of PBM and H2 water was safe for people with PD and could alleviate the disease severity, particularly in the mood and cognitive domains. My question is, I guess I don't know why not just do photobiomodulation and not include H2 water. Would that affect the outcome? I don't know. It's an interesting study, but I guess I don't understand the point of combining both. And the last prospective study is photobiomodulation enhances memory processing in older adults with mild cognitive impairment, a functional near-infrared spectroscopy study, which I think is interesting because one of my main issues with regards to conducting studies, say for instance, for mild traumatic brain injuries, is we don't have any objective means of proving that there's actually an improvement pre and post treatment. Mild cognitive impairment is the intermediate stage between normal aging and dementia, in which older adults with MCI demonstrate subtle cognitive impairment that's different from normal aging, but does not meet the criteria for dementia. Some changes to their cognitive functions, such as increased forgetfulness, but the individuals remain capable of functioning independently, and there's a higher risk of developing dementia in the future for these patients with MCI. Functional near-infrared spectroscopy is a non-invasive means used to monitor the hemodynamic responses evoked by brain activity. It's an optical imaging method that uses light in the near-infrared spectrum, remarkably similar to what we use, 650 to 950 nanometers. It measures quantitative changes in the concentrations of oxygenated hemoglobin and the oxygenated hemoglobin in cerebral blood, and has been shown to correlate with the blood oxygenation level dependent signal as measured by fMRI. Studies have shown that the hemodynamic level increases as tasks become more difficult, indicating that the tasks may require more neural effort from the subjects to perform. Studies that show that young adults exhibited a significant reduction in frontal hemodynamic levels showed difficult tasks after a single PBM stimulation. PBM could have a positive effect on neural processing and could reduce the amount of effort required to complete cognitive tasks. So we had 18 subjects with no known history of head injury or epilepsy, psychological or neuropsychological disorders, or memory or other cognitive problems, had a score of more than or less or equal to 3 on the short memory questionnaire, which indicated significant subjective memory complaints, normal or corrected normal vision, and classified with MCI according to the criteria proposed by the National Institute of Aging, as described below. Materials, they used a 16-channel FNIRS system from Spectrotech, Japan, which was used to measure the relative oxyhemoglobin and deoxyhemoglobin changes during visual memory span tasks. And for PBMT, they used the Wizafori 3800 model, which contained 9 LEDs placed on various areas in the head, which corresponds to the EEG attachments. Emitted 810 nanometers continuous wavelength light, irradiance of 20 milliwatts per square centimeters, and is considered a class 1 device by the FDA. Stimulation was 350 seconds with a fluence of 7 seconds per square centimeters. So the procedures, all subjects underwent a computerized cognitive assessment with a Corsi block test, and these are the results. So as you can see with the test, there was an improvement, bigger improvement, a statistically significant improvement between those who treated with PBM versus those in the control group. With regard to the Corsi block test. With regards to the oxyhemoglobin changes using the FNRI measurement, they showed here that there's actually a decrease in oxyhemoglobin use in the experimental group versus the control group. And what they're trying to say here is in patients treated with PBM, they don't use that much energy in thinking. Even though there's an improvement in blood flow as evidenced by fMRI, the use of oxygenated hemoglobin was far less, and there was less stress on the brain using PBMT for these conditions. And the discussion was older adults with MCI demonstrated improved visual memory immediately after one PBM stimulation, which led to a reduction in the hemodynamic response associated with the visual memory task. This reduction in the hemodynamic level was observed across all the frontal lobe regions. These results suggested that PBM may enhance the efficiency of functional neural activity and may be an underlying mechanism related to the improvement in cognitive and behavioral performance. And PBM may be a potential intervention for older adults with early signs of cognitive decline. All exciting things that we may see in the future with PBM, especially for patients with mild cognitive insufficiency. Thank you. And see, there's a few questions. Are there any studies using irradiation of the eyes to affect changes in the brain? There is one study, not recent though. I believe there was a study 2 years ago. They were treating the eye with red and near infrared lights. And they have shown, and this is in mice, they have shown that there was a decrease in amyloid beta plaques just by treating the eye, not directly treating the brain. Do you know the efficacy in treating the brain post carbon monoxide poisoning to improve cognition deficiencies and revascular compression of CN7 resulting in hemiplegia? You know what? This is an interesting study. Thanks for posting this. Because when you have carbon monoxide, blood tends to favor carbon monoxide if it's available. So if we can provide increased oxygenation and PBM, maybe this is a study worthy of pursuing. Can you tell us a bit more about the future of Meditech's clinical research and how can we volunteer? We have one research study using evoke-related potentials for concussions that is now on our website. It's being advertised on our website, and if you're interested, just feel free to send me an email. It's in 2 sites, one's in BC and one is in our site here in Toronto. And we're also conducting one clinical study for sleep, a non-apneic sleep disorder secondary to concussion. We almost had one recruit, but he didn't fulfill the eligibility criteria. So this is something that also excites me a little bit because there isn't that many studies purely concentrated on sleep for concussion and for photobiomodulation therapy. So and we do tend to observe that patients tend to be a bit more fatigued or sleepy after treatment. So this might be something that might have a good future or good outcome.
That's awesome. Thanks so much, Randy. Really appreciate that update, and we'll be sure to have you as a guest speaker in the near future as well. So,
are you sure?
No, it's great information. Maybe a little bit longer than I anticipated, but you know what? It was excellent review, especially of this neurological research. So thanks so much. And what I'm going to get through my material. So I'll ask you to stop sharing your screen now.
There you go. And that's enough Squid Game.
Yeah. All right. Well, thanks very much for joining us today. Appreciate it.
Okay.
Okay, so we've gone definitely a little bit over time, so I appreciate you hanging in there. I'm going to get through a bit of my research that I sort of looked up, and we'll call it a day. So mine obviously aren't on the neurological aspects. These are studies that were done in 2021 and some of the latest research on different types of conditions. One entitled Laser Phototherapy, Is It the Light at the End of the Tunnel? And this is a reference, an editorial to some research that was done as the first in-man use of percutaneous, which just means on the skin, laser therapy for the management of electrical storm. You may or may not have heard of something called electrical storm. And this is essentially at least 3 or more distinct malignant ventricular arrhythmias occurring within 24 hours. So essentially it's electrical instability of the heart, usually comes after myocardial infarctions or different heart conditions. So it can be a progressive disorder, and there's different ways of treating it medically. But this novel study looked at using specifically laser therapy to do that. So what they did was, it was a prospective single center descriptive study, so not a randomized controlled trial per se. And they used laser probes directly over the stellate ganglion. You can see the location of the and I've talked about the stellate ganglion before for treating autonomic disorders, even migraines, complex regional pain syndrome. There's even some other interesting links of treating the stellate ganglion for sympathetic, sort of excessive sympathetic tone, you might say. So location is on either side. It's in the jugular notch on either side of the cricoid cartilage in the neck. You can see where that is on the diagram that I've shown you there. So essentially, and I won't go into all the details, as much details as my colleague Randy, because he's a smarty pants. So I'm going to do more of a generalized review. And so what they found here was that the acute effects of phototherapy resulted in successful acute therapy, meaning successful therapy of these electrical storms in 64% of the patients. That was 7 of 11. 2 required additional medical therapy to manage their ventricular arrhythmias. However, in 4 remaining patients, 2 had reduced ventricular arrhythmia and 2 had no change in the VA and required more invasive therapies. So they concluded, in fact, that it seems that laser therapy done directly over the stellate ganglion, because it's linked to the sympathetic autonomic nervous system, it seems to block this excessive tone that can actually lead to these arrhythmias. So basically what you're doing is you're quieting the autonomic nervous system, and this seems to be able to help lots of different conditions related to autonomic nervous system disorders. So it was really interesting that they came across this, and they basically feel that this might be a non-invasive way as opposed to a injection block of the stellate ganglion that they oftentimes would do. This next one was really interesting, I thought, and it has to do with patients that have non-alcoholic fatty liver disease, essentially associated with obesity, along with the use of traditional Mediterranean diet to help these patients. So we know that abnormal excessive accumulation of liver cells and fat is oftentimes called NAFLD, or non-alcoholic fatty liver disease. This is where you get this fat accumulation not associated necessarily with, say, alcoholism, and you also get elevated liver enzymes. So it's something that would be imaged by an ultrasound or an MRI, and also blood tests for the liver enzymes. Of course, we all know about the Mediterranean diet. It's mainly plant-based that uses fat sources like olive oil and fish. It's well known to help reduce cholesterol and help with fatty liver and those kinds of issues as well, and obesity-related diseases. So there have been reports and studies shown that photobiomodulation, or of course LLLT, the old acronym, can positively reduce cholesterol and triglyceride levels in addition to liver fats. It's quite fascinating how that may work. So this particular study, it was randomized, controlled, parallel 2 groups. So they looked at 60 patients that had NAFLD, 30 men, 30 women. You can see the age group. And on the right, you can see the parameters that were used. I won't go into any depth, but they just basically used red light, 660 nanometers. they were using fairly low-powered diodes, and but a lot of them, and they were placed over the abdomen, so basically over the belly fat region. And here are the results. So if you look carefully, you'll see the study group on the left and the control group on the right. The total cholesterol before for the study group was about 216, and after the Mediterranean diet and photobiomodulation, it was reduced down to about 187, 188, whereas the control group started at 219 and finished at 206. So, not much of a change there. And then if you look at other parameters like LDL was statistically reduced in the study group compared to the control group. And then if you look at triglyceride levels, same thing. So I need to go back here. My apologies. So overall, you can see that the use of photobiomodulation, also in conjunction with Mediterranean diet, was quite beneficial. So the overall results suggest that these two combined can be a valuable tool in helping treat patients that have obesity and, because of that, NAFLD. So this might be helpful for reducing hyperlipidemia, elevated liver enzymes, and so forth. So it's one of those things where it might make sense to include that when you're trying to lower your cholesterol and treat these types of issues. This next paper was really fascinating, I thought, because what they did was they looked at the effects of anesthesia of low-level laser therapy. So high amounts of laser light can actually cause a temporary analgesic effect. And this study was used to see if it was helpful in children that were about to have an injection for numbing teeth for dental work. So it was a randomized controlled crossover double-blinded study with 60 children ages 6 to 9. Before local infiltration anesthesia, so a needle, only topical anesthesia was applied on one side. On the other side, it was LLLT. And so they used a laser diode. They used a fairly high energy density, 300 milliwatts of power, so it was class 3B. And so this created what we refer to as a pre-anesthesia effect. So the injection pain and anesthesia efficacy were evaluated subjectively and objectively using different scales. And the results were that the no pain and severe pain rates were 41.7% and 3.3% for the laser group. And you can see it lower in the control group, meaning that the laser group had a very profound effect at reducing the pain perceived by these children in dental anesthesia. So again, it's a really interesting application for topical anesthesia by using lasers. And I've talked previously about how this mechanism works. So if you're interested in that, you can search some of my old webinars and look for that information. So basically the results, as you can see here, that the children actually preferred the injection with topical anesthesia and the laser therapy combined together as opposed to just one. So it seemed to have an additive effect when you're looking at anesthesia. This other one we get asked a lot about as far as treating hearing conditions, whether it's hearing loss or tinnitus, those kinds of conditions, Meniere's disease. And this was a study done in 2021. It was a bibliometric study. So basically they looked at all the different studies that had been published to date and kind of did a report on it. So research has indicated that laser therapy can not only prevent cochlear damage by exposure to nose, but also can become a treatment for noise-induced noise-induced hearing loss. And so photobiomodulation represents an effective tool to control and limit cochlear oxidative stress and induction of cochlear inflammation located specifically in the organ of corti. So essentially what they're saying here is that laser therapy seems to have what we know it can do, which is anti-inflammatory effects and help heal different tissues. So the photobiomodulation they felt can be used as a therapeutic alternative to deal with these high levels of oxidative stress in these hearing cells specifically. And this can help people recover from or even reduce the progressive hearing loss when, say, due to occupational noise, for example. So another study looked specifically at transmeatal, which is directly in the ear itself, for recovery of the vestibular system of rats with bilateral ototoxic vestibulopathy. Now, when applied to tinnitus, there's been some good and not so good or controversial results. Some researchers have included that LLLT, after LLLT, they can actually show improvement in tinnitus, but other studies have shown, in fact, that this effect is very short-lived and may not actually be beneficial. They looked at a whole bunch of different studies, everything from acoustic trauma, Meniere's, ototoxicity and hearing loss and tinnitus. And you can see they use different types of wavelengths, typically infrared, although they also did use red in some of the studies, but they oftentimes would do both or just one or the other. And all this research to date has shown overall a conclusion that laser therapy can help patients recover from hearing issues and perhaps help in a non-invasive way or in conjunction with medication to improve their hearing functions. But of course, it was observed that there is no well-defined protocols. And again, there's not a lot of research out there, so we're still trying to learn this. This might be something that maybe Randy can look at and who knows, maybe get involved with the study as well. This next paper was on spinal cord injuries, and it was the actual effect of low-level laser therapy on the pathophysiology and the locomotor or the muscle recovery after traumatic spinal cord injuries. So it's a systematic review and meta-analysis. They looked at 19 articles specifically that met their criteria, and the results showed that regardless of the laser type, whether it was in the red or the near infrared, it could suppress inflammation and result in inflammatory cells to decrease inflammation and help with wound healing. Laser therapy is also in these specific wavelengths for use in more than 2 weeks, significantly improved axonal regeneration and remyelination as well. So it's important to understand that you have to do subsequent treatments over a fair length of time to get this type of improvement. The improvement in the locomotor recovery was more efficient using near infrared, which makes sense because of its deeper penetrating effect as well. And the energy densities were used anywhere up to 100 joules per centimeter squared. And the treatment duration, again, at least for a couple of weeks. So they concluded that laser therapy showed promising potential to modulate these pathophysiological changes and events and the recovery from spinal cord injuries. This paper I threw in there because it talks a lot about nitric oxide, and nitric oxide is a really interesting molecule. And we talk a lot about it with respect to photobiomodulation. The effects of nitric oxide in the human body are essentially concentration dependent. Higher concentrations actually are inhibitory, can have damaging effects. It can promote cellular apoptosis or cellular death, deamination of DNA. So it can cause damage to DNA. It can cause nitrosylation of important enzymes and receptor proteins. So it's actually quite toxic in higher concentrations. And it can also generate fairly high levels of reactive oxygen species. But lower concentrations of nitric oxide, they can serve as signaling purposes for increasing angiogenesis. It can lead to vasodilation, a reepithelialization, as well as anti-inflammatory environment as well. So at low levels, nitric oxide acts as an antioxidant by reducing these potentially oxidizing molecules and can neutralize lipid peroxidation. So if you look at sort of nitric oxide and how it might be helpful in the realm of clinical application, you can see it can perhaps help with bronchodilation and lung issues. So we're thinking of COVID, for example, or post-COVID issues. It can help with the immune and inflammatory response with respect to even innate immunity and cytotoxicity. We talked about its ability to cause vasodilation even increase in uptake of glucose. Of course, we know it can increase mitochondrial activity and even muscle performance. It may be a value in erectile dysfunction where nitric oxide can play an important mediator for that. For neuroprotection and neurotoxicity, I know Randy talked a little bit about this as well. And in general, vasodilation, it may have positive cardiovascular results as well. So lately, they've been looking at red and near-infrared wavelengths. So it was reported that these wavelengths can release nitric oxide from human skin itself. And they observed an increase in nitric oxide concentration, specifically by irradiating human keratinocytes as well as at 980 nanometers. So they're looking at other wavelengths as well. And most importantly, they did not find any reported side effects caused by nitric oxide released mechanisms using light. So it doesn't produce too much nitric oxide that causes these potentially negative effects. But the in-organ tissue response may be limited. So in other words, it's good to do this type of therapy and to modulate nitric oxide, but you also need to look at other methods as well. Specifically, they talk about dietary nitrates. Many of you may have heard of beetroot. Specifically, it has high concentrations of nitrate. This is really beneficial for reducing blood pressure. So if you combine beetroot supplements, supplements is the way to go because you'd have to eat a lot of beets to get enough nitrate in the beetroot itself. In combination with photobiomodulation can be very beneficial in helping with hypertension. And of course, dark green leafy vegetables like spinach also have high concentrations of nitrate. This next peer-reviewed paper looked at chronic renal kidney failure, and not so much treating the renal failure, but the subsequent muscular issues that are associated with chronic renal failure or kidney failure. So this has to do with muscular homeostasis. So in chronic kidney failure, what happens is you get this altered state of that induces metabolic acidosis and chronic uremia. This can affect the actual ability of muscle tissue to contract, its oxidation and enzymatic modification, such that you have muscular issues associated with progressive chronic kidney failure. So in this specific paper, they looked at photobiomodulation as a monotherapy between the second and third hour of hemodialysis sessions 3 times a week for 8 weeks, so about 24 sessions. And the photobiomodulation was at 6 points on specific areas of muscles, including the vastus lateralis and rectus femoris, so on the quads, basically, the quadriceps bilaterally. So these 33 patients all had chronic kidney failure and were on hemodialysis for a period of equal to or greater than 3 months. And they were randomized into a control group as well. And here you can see they basically use 810 or near infrared wavelengths, 200 milliwatt laser diodes, so class 3B, but they used 5 of them. And you can see the other parameters there as well. And if you look at the results, you can see clearly that there's an improvement in the functional capacity of the intervention group, an improvement of the muscular strength, also muscle thickness. I won't get into all those, but also reduction of pain as well and fatigue. So overall, they felt this was a very beneficial modality to use in patients to help recover or improve their muscular function from those suffering from chronic kidney failure and were on hemodialysis. So I didn't mean to rush through that, but it's been a long webinar. So join us for our next webinars in January. The first one will be on bursitis. The second one will be on wrist sprains and fractures.